Thank you for watching. If you want to learn more about how to stay healthy, stay tuned and listen to what the doctors have to say. It's awesome to have you with us again. You are always such a reservoir of information. And we've talked so much about COVID and all sorts of other things. But, people are ignoring some of their other comorbidities or ailments that they have because they're so focused on COVID. And you're seeing some serious advances with osteoporosis and some things that are going on. So thank you for being with us, Dr. June, and also Keith, appreciate you being with us as well. So talk to us a little bit about what you're seeing in the patients that are coming as it relates to osteoporosis.
Well, as you know, and I guess it's forgivable, a lot of people are hyper-focused on the pandemic, hopefully becoming the endemic soon. The problem, though, is that a lot of our chronic and acute illnesses are being forgotten or not being screened for or being wholly ignored by not just the patients, but sometimes other providers. And that's understandable, but as we move forward, we really need to come back to to screening again and addressing these. And one in particular is osteoporosis. A lot of times people think that osteoporosis can wait. It's a slow disease. A broken bone, it won't happen to me. It's no big deal, and we can fix these things. And the problem with that is that osteoporosis is actually the number 1 cause of preventable death in the aging population of the country. It is very serious.
Preventable death?
Preventable.
Wow.
Yeah.
I didn't know that. Wow.
Yeah. So I wanted to bring it to people's attention that it's important to screen for it in the appropriate population because we have now state-of-the-art, cutting-edge diagnostic tools that are brand new just in January 1st onward that we can now use to help adequately actually assess someone's risk of a fracture, whether it be in their hip or their spinal column.
How do people even know to go to the doctor, go to the rheumatology or wherever they go to the rheumatologist to be assessed? How do they? What are some of the signs that they would see?
Well, a lot of times, and I hate these terms, that osteoporosis is referred to as the silent killer, but hypertension was called that too. So it's one of these things that it's just you're not aware that you have the problem until there's a problem, and when there is a problem, it's catastrophic. Such as you fall from just a slip on ice. I say this, we've all slipped on some ice in Michigan. We've all took a tumble, hit our knee, fell on our butt, no big deal. But one day you do that and it wasn't even that bad of a fall and pop, your hip is now broken or you have this stunning pain down your spine because you've now compressed a spinal column just from a light fall. And that's how you find out I had osteoporosis. And that's kind of a backwards way of finding it out is we should have screened it first and prevented it and reversed it way ahead of time now that we have the tools to do so.
That's interesting because I hear a lot of people, who've had hip problems or knee problems. And the question is always, did you have a problem first and then you fell and broke your hip? Or did you break your hip and then have a problem? Now, which came first? And they already had some things going on, which caused the fall, which caused, et cetera. So the signs then again are just being checked out? Or how do you know? I mean, how do I know if I'm at risk? If I fall, that I'm more at risk than perhaps someone else of having osteoporosis?
There's a long answer to that, but that's why I have Kevin Duffy with me here, and he had worked as a orthopedic PA for many, many years, and they're on the end of it is that's exactly how they found out that they had osteoporosis. If you want to say a few things about the orthopedic approach.
That is exactly how they find out. They've got an underlying problem, with their hip or whatever, and then they fall, they break their hip, and lo and behold, you're doing the surgery and you say, boy, the bone's like mush. And you go ahead and get a bone density, and they have full-blown osteoporosis.
So, and we've talked a lot about prevention, okay, making certain that you don't get to that point where you have issues. What are some tips that you could give people that help to keep their bones and their bodies healthy so they don't even have to, so they can, I don't want to say prevent, because you might be able to prevent it, but reduce the chances of getting?
Any weight-bearing activity. Just walking is beneficial to putting on bone mass. Checking your vitamin D levels Uh, Everybody probably sees that in the news today. A lot of people are low. There are even some diseases like psoriatic arthritis, and psoriatic patients are traditionally low in vitamin D. So there's those things. And then elderly people, I tell them a lot in the wintertime not to be shy about using a cane or some type of an assistive device so they don't slip and fall. And there also, I look at people's medicines that they're on, because some medicines can cause osteoporosis. I had a young person on high-dose Lexapro for depression that ended up getting a hip replacement done at 32 years old. Oh, wow. And when the surgery was done, the surgeon felt the bone was too soft for his age, and lo and behold, bone density at 32 years old, he's got osteoporosis.
Wow.
So he changed his medicine, changed his diet, get him on vitamin D, get him to exercise, be more active, doing very well today.
Wow. Dr. June, I know that you have fought a long battle for a long time about, RX drugs and prescriptions and all that, and we won't get into all of that today because I know you're very passionate about it, but what are some questions that people should ask if the doctor is prescribing a medicine? I think you shared with us once before that the first question you ask is, how long will I be on this, or what does it take to get off of this particular medicine? Because it seems as though there's an overabundance of medicine being prescribed.
Well, we live in modern times, so not going to say young versus elderly, but everybody nowadays is Google savvy. So the first thing a patient says is, what can I expect from this? Do I have to be on it forever? And I'm going to go ask Dr. Google. And when they read on that, you're going to find what you're looking for. And that's the problem with that is that even the rarest of side effects have to be listed, and they're not told you, they don't say how rare they are. They just simply list them, this could happen. So even a 1 in 3 million side effect, which should be irrelevant, shows up on that list. So by the end of it, you say, why is Dr. June trying to kill me? And they look at this list, and why would he put me on this for something I don't even think I have, osteoporosis? So the statistics are quite clear on this. We've been under-treating, under-prescribing osteoporosis since the beginning of time. There's been a lot of pushback against the use of these medications and the concept that they have a lot of nasty side effects. But after the data has been done, it's been shown that we've been undertreating to the point where there's been millions of fractures that were not necessary, that have ended a lot of people's lives and shortened a lot of people's lives. And almost every one of us knows someone who's never been the same after they've had a spinal compression fracture or a broken hip, never the same after that. Right. And that makes a huge difference to know that it could have been prevented. You don't have to have these problems.
What kind of tests are taken so that you know whether you have a vitamin D deficiency or that you need to do more? I mean, do general blood tests. Does that tell you, or?
It can. There's 1,000,001 reasons can cause osteoporosis, but we need to screen them first, and that's men over the age of 65, women after menopause, or anyone with an autoimmune or inflammatory condition, anyone with a thyroid disorder or parathyroid disorder, and then there's a whole slew of rare things that we don't have 4 hours to get over. And that's why we need to have these conversations with our rheumatologists, our endocrinologists, our primary care, or our OB-GYN. These are the major players in the osteoporosis scene. Then they will get a bone density test, and traditionally that's a DEXA scan. DEXA means dual energy X-ray aspirometry. And that DEXA scan, or bone density scan, will give you a T-score. We've now developed tools that also gives you something called a FRAX score, and another tool that's out just this year using new equipment, which was really going to change things for the better, called a trabecular bone score, or TBS. Those 3 scores with up-to-date equipment, that people that do this all the time have this equipment, will allow you to give people the most accurate prediction of their risk for a fracture. And so we now offer that, and a lot of major centers offer that for bone health, and it's going to change pretty much everything about who's really at risk and who isn't.
That's excellent.
Yeah.
And so if someone's listening, do they need a primary care physician referral, or can they call their rheumatologist on their own, or do you need a referral in order to get those if you think that you're at risk, if you have some symptoms or reasons to believe that?
Oh, it's insurance-based. Some insurances will not allow you to do anything outside your primary care's permission. Okay. And other ones is if you ask for a referral, you can get it. So it's across the board on this one. Most primary cares don't have any problem whatsoever sending to a rheumatologist or endocrinologist if they can get you in at a reasonable time.
Okay.
And most are open to it, so
Okay.
especially centers for osteoporosis.
Now you mentioned vitamin D. You mentioned weight-bearing exercises. Where do people should just take over-the-counter vitamin D? How many milligrams should people take? Are there other things they can do? Can get out of their food or sunshine? How do you?
Well, that's a good question. About 95% of a human's vitamin D comes from sun. So there's an oil on your skin called 7-dehydrocholesterol, and ultraviolet light transforms that into vitamin D. Your skin absorbs it. So that's one thing.
In Michigan, that's a problem, though, right?
Michigan, that's a problem. And then, it's always good to get a lab test and see where they're at, or if the person is fair-skinned. And then a lot of people think people of color, because they have more melanin, can't get a low vitamin D. And it's absolutely not true. And so I do a cutoff. If they're below 20, I give them 50,000 units a week for 16 weeks. And then I check it, and it'll usually be normal. And then I have them take over-the-counter, and it's vitamin D3 over-the-counter. I have them take 2,000 to 5,000 a day for up to 3 months. I check it again. If it's low, then they maybe just have an absorption problem. So I generally put them on the high dose all the time and then just monitor their level. So
Can you get too much?
You can get too much. You really don't want to go over 100. So I like them to be in the 50 to 60, 70 range. That seems to work.
So if you're listening to this, and you obviously are, don't just go start swallowing a whole bunch of vitamin D, right?
Because you can overdo it.
You can, yeah.
And then you can get calcium deposits and stuff in muscle, which is pretty painful. And another thing I'd like to add, Dr. June brought up, is anybody that has an autoimmune or an inflammatory condition, even in their 30s, you might want to do a DEXA scan and screen them and see, do they have something going on from their disease? Do they have something going on from the medicine they're taking? Because if you can catch them early like that, you can maintain them, you can do real well. And, people have this fear of taking the medicines because there's I think it's a misnomer out there, like, atypical femur fractures are resorption of jawbone. And do those things occur? Sure, they occur, but do you see them? Hardly ever. And so I think you have to look at, what's going to get you. Is the medicine going to get you, or is the disease going to get you?
Yeah.
And if you do nothing, clearly we all know the answer. The disease is going to get you.
Right.
And you see a real healthy person in their 60s or 70s, and all of a sudden, bam, they got a spinal compression fracture. Their life is forever changed. Forever.
And so much of this, again, I keep going back to early detection and preventative types of things that people can do. There are a lot of things that are unpreventable. But you said osteoporosis is one of the things that is most preventable, one of the most preventable deaths. So
Totally agree.
yeah,
Right.
Number one, that's scary.
And that's even more so true now.
Yeah.
Whereas medications we had in the past, and that's the ones that people usually had the most fear of, were a product called bisphosphonates. And they are successful at slowing and sometimes stopping the progression of osteoporosis. But now, as modern medicine has chugged along, we have the ability to reverse osteoporosis and to do it faster and safer than ever before. And now that we have the ability to reduce risk and even reverse the osteoporosis and bring your bone density back, we were able to get people back to the densities they had in their 30s.
Oh, wow.
And that is not a bad goal to have for our patients who are high risk. And so we're now just walking into this realm. So there's not a lot of guidance on it from a lot of the colleges of endocrinology or rheumatology, because the ability to do this is relatively new. And the side effects are less than ever before, and the results are the best they've ever been. So I'm excited about this.
You really hear a doctor say you could reverse this. I mean, so that's huge. So don't be afraid. The earlier you detect it, the better your chances are of being able to reverse the disease. So when you say early detection, again, I keep going back to this, and I'm sorry to harp on this, but when you go to your primary care physicians, they just give you a certain set of tests. What do people ask for? Say, test me for vitamin D deficiency? Do they say, test me for osteoporosis? What do they say? What do they ask their physician?
Well, a lot of people sometimes have to advocate for themselves, and it's not because the primary care is not doing the right thing. It's there's a million and one things, COVID being one of them,
Right.
that is on the mind of the primary care,
Mhm.
and a million preventions, whether it's colon cancer, breast cancer, osteoporosis, hypertension, diabetes. And sometimes these things are missed. So if this is a concern to you, or you have a family history, or my mom had this, my cousin had this, my brother, my sister had these problems, that's when you ask your primary care, my family's got problems, I'm worried about it myself. Can you order me a bone density test? Can you test me for vitamin D deficiency? What's my thyroid looking at? And they're going to be fine with it.
Good.
Right.
It's good to know. And,
Also, anybody that has like a low impact fracture,
mm-hmm,
you know, you always want to check them. Like, hey, I broke my ankle. Oh, what happened? Well, I just slipped and fell down, you know, in the house, or I tripped on a rug. You'd be pretty suspicious about that.
Yeah.
I have a young lady right now with lupus that had foot pain last summer, went to an urgent care, took an x-ray. The x-ray was normal. And the nurse practitioner there said, I don't know what's wrong with your foot. And then she came here, and you know, she was limping, and I said, well, do you get an achy pain at night? Because stress fractures, you'll get an achy pain at night a lot of times. She goes, yeah, it aches at night. I can't walk on it. So I MRI'd her foot, and she had a second metatarsal fracture in her right foot. And that went on to heal. And lo and behold, just a couple months later, she gets another one in the third metatarsal.
Uh-oh.
Did a bone density minus 3.1. So she's
Oh,
got
wow.
osteoporosis.
In her 30s?
Yeah.
She's in her 40s.
Or 40s. Oh, wow.
And so, you know, she's somebody we want to get really aggressive with. She's only in her 40s. Can you
Right.
turn it around? We can today.
Yeah, yeah. What's the number one question? I mean, this is a question for both of you. What's the number one thing that people ask you about when they come in? What's what do you hear most frequently? What question do you hear most frequently?
Related to osteoporosis.
Yes.
Right. One is, do I have to be on medication? It seems like everyone hates the idea that I might have to be on a med. And the answer is yes, but not forever. With some of these newer agents, if we get them back into normal ranges and we get them follow the protocol, sometimes they can be done with those meds, and that's it forever. So there's really new things on the horizon, which is changing the game completely.
Well, I really appreciated when you shared with us once before that one of the first questions you should ask your doctor when they put you on a medication is, how long do I have to, what's the plan for getting me off of this medication?
Right.
I mean, so that you're not on them forever. I've shared that with so many different people. I just think that's excellent advice. And maybe, maybe it is more of a long-term thing, but at least you understand what the ramifications are. What do you get asked the most?
Pretty much the same thing.
Yeah.
How long do I have to take this medication?
Yeah.
Side effects. People always ask you the side effects.
Yeah.
And I go over them. And sometimes this sounds funny, but sometimes if I get somebody that's really reluctant, I try to educate them about their disease first. Then I tell them about the medicine second and the side effects. And if they're really reluctant, I say, you know, I can lead the horse to water, but I can't make the horse drink the water.
Right.
And that kind of brings them around to thinking about themselves.
Yeah.
And then I use the analogy again, you know, you got to it's the risk versus the benefit. And, you know, if you got a lady in their 40s that's got osteoporosis and you know you can turn it around and make it normal, in my eyes, you know, the risk-benefit ratio is there.
We've got about 2 minutes left, and I'm reminded of when I used to work at the Kellogg Foundation, and they didn't fund research. They said, because we already know so much more than that, which we do. So they didn't fund a lot of research at the time. Same thing here. We know to walk. We know to get a little sunshine. Name in the minute and a half or so we've got left, tell people 3 things they can do right now to kind of help offset their the risk of getting osteoporosis.
One, eating right.
Mm-hmm.
A lot of people think that in terms of if I take more calcium pills, I'll be fine. It's actually shown eating a very healthy diet with calcium and skipping the calcium pills is way safer. Mm-hmm. Once again, knowing your vitamin D and taking the adequate amount. Reducing the amount of caffeine drinks in the day, because sometimes we overdo that. So 3 or less is still relatively neutral. Anything above 3 can be detrimental. Drinking more than 2 alcoholic beverages a day is associated with worsening osteoporosis, and a sedentary lifestyle is more important than anything else I just said. Not moving, not exercising, not doing weight-bearing exercises, probably one of the biggest things.
Wow. Wow. And when you say eat right, very quickly, what does that mean?
Lots of vegetables, green vegetables are good for you. I'd like to add something to him too. Calcium supplements you don't need them. Humans need 1,000 milligrams a day of calcium. there's 600 milligrams in a little cup of yogurt.
Oh.
So 1,000 milligrams a day. There's a lot of side effects to elemental calcium supplements. And then the vitamin D3 is so important.
I just love you guys. Thank you. You're so much good information. Appreciate it. Thank you so much for all that you do. Appreciate you being here today.
Thank you
Thanks for having us.
Thank you. Craig, we hear people talking about the dollar is going to be useless after a while. It's no one's going to have our current currency.
Yep.
How does that factor into any kind of investment decision?
That's a great question, because when I sit there and talk with clients, they're always concerned about the valuation of the dollar. Well, the value of the dollar has got to be based off of something. At one point in time, it was based off gold. That then got basically removed from the gold standard, and now it's based off of the strength of the United States economy. So if the United States economy becomes weak, typically the value of the dollar starts to drop. If the economy is strong relative to other economies throughout the world, then the dollar becomes strong because people are now investing into the strength of the United States economy. So that basically is where the valuation of the dollar becomes. Now, if people are concerned about the valuations of the dollar or relative to other currencies or other economies, that's when I start talking with them about incorporating large cap growth strategies within their portfolios, or even large cap investments, investing in large cap companies that typically have a valuations of $50 billion plus.
Wow.
So why that? Because those companies are already doing business in multiple currencies, in multiple economies. And so as they start to do well, then they're going to be able to hedge against that, and basically those companies are already making the hedge bets, if you will, from different currencies. For an individual to try to incorporate that
Can't
themselves,
pick it off yourself.
and you don't want to,
Yeah.
because it gets
You're
very
right.
complicated. Which currency do you compare with? The Canadian currency to the Japanese currency? Because now you're buying and selling, and then there's so many other factors that start to play in all these different elements, such as the politics of China, the politics of Japan, the politics of Russia, if you're going to compare, the politics of Canada, if you're comparing the American dollar with that of the Canadian dollar. So are you going to be swapping out the American dollar and changing it with the Canadian dollar, and then when the Canadian dollar increases in value relative to the American dollar, are you going to switch it back to buy the American? No.
You know what I'm learning from this? You know what they tell you? Don't try this at home. Call your professional.
Absolutely.
All right.
Absolutely.
Thank you so much. I
Thank you,
appreciate
Paula.
you. Amy, thanks for being here. All right, let's talk about dementia. What are some of the early signs of dementia that people should look out for in their loved ones? I mean, how do you know the difference between just forgetting and when there's really an issue going on?
Well, normally the big one is when people start getting lost. They're either getting lost in their homes or they're getting lost in their neighborhoods. Doctors might start saying, okay, maybe we need to think about not driving. A full dementia diagnosis would require an actual doctor or neurologist to come in and do that assessment. But families can be on the lookout for little things, like forgetting to turn off the stove is a big one. But even little things like grandma forgot to rinse out the cups after dinner, so everything tastes like soap. So you just kind of want to make sure that those things, it's like, okay, well, how often is that happening? And it's also going to be more determined on how often are you visiting. So is this loved one, are they alone a lot? Are they not having the social activities that they used to? Are they not enjoying things? Are they just kind of foggy? Now, normally those can be normal things.
Right.
We all get that way.
Right.
But at the same time, you have to start looking at other things. Like, have they started, is it farther along than you think? Because a lot of times it's easy to hide, especially if you're on the phone.
Right.
How are you doing? I'm fine. But then you get there and you're like, okay, well, there's been a little bit of a hoarding thing going on here. Or you start finding money in weird places, or you start finding different things that shouldn't be where they should be. So you've got, cups and things on the bookshelf, that it's odd and random but those are things to watch for. And you want to make sure that you are keeping on top of that, because, if it is an actual dementia diagnosis, you're definitely going to need help later down the road.
Absolutely. So look for the signs and don't be afraid to speak up. Thank you, Amy.
You're welcome.
During these winter months, inside, outside the home, people are falling, slipping and falling. What do they do after they've fallen? Should they jump right up? What do they do?
Well, sometimes they pop right up.
Yes.
But you got to
That's
take
a
a quick assessment and say, what hurts? Am I oriented? Kind of feel around a little bit because sometimes you're just a little dazed. But
Yes.
generally speaking, you go by pain. Pain is the number one parameter. The problem that we run into is that people are not real excited about going to the ER right now, even Medicare Center. They just say, well, I'll sit on this and want to know. So you have to ask yourself, what did I hurt? Is it an arm? Okay, fine. But if I hit my head,
Yes.
I got to think about that. And
Right.
maybe I'm going to go in there because you really do need to be assessed.
Right.
If you really think you broke something and it's hurting like heck, you got to, don't just sit around and wait.
Right.
You got to go in there and get it checked out, regardless of what's going on with COVID.
And so what's the first thing you should do? Assess the pain, Courtney?
Assess the pain, yeah. Check their mental state. They should just how they feel baseline, if they can get up, if they cannot, and making sure that there's someone around that they can ask for, especially if they know that they are more prone to falling, having the precautions set in place prior. But some people don't like to go to the ERs again because it's COVID.
Right.
They're not interested,
Right.
but it is still important because people still fracture, people still get head injuries.
Right.
So.
That's right.
Should
You
they
can take
wrap
a
it,
little-
put ice? Or
Well, you can take a little Tylenol. You can take some, ibuprofen. People will normally do that, but don't keep taking it over and over and over
Right.
again, especially if it's hurting more and more. You got to
Exactly.
check it out.
heat, ice? Which one?
Ice is always good in regards to controlling swelling initially. So that's the first thing you would think about. And if
Yes.
something's puffing up, you really got to consider what's going on.
And elevation?
Well, elevation, depending on what part you hit,
Yeah.
if it's your head.
That's it.
It's already
It's
up
hard,
there.
yes.
Right.
So that's a different story. So
Yeah.
I think the logical things that people know what to do, it's just a question of should I go into the urgent care ER and the concerns they have about what they're going to see when they
And
get
you got to
there.
weigh the
Right.
the
And there's
choices,
this,
right?
they lay back a little bit more. And they'll say, I'll be all right tomorrow. Well, maybe you will, maybe you won't. So
Yes.
be smart about it.
Yes, absolutely,
Mhm.
absolutely. And when they come in and they get treated, then the sooner they get treated, the recovery's a lot less at that point, right?
Very, very much so.
So don't be afraid to make some wise choices if you should happen to fall, and check out your rheumatologist, your PCP, or a primary care physician, or whomever. Thank you so much.
All right.
Appreciate it. Thanks for being here. We hope we're bringing you news that you can use, but if you have a question or you have a topic that you'd like for us to cover, go to our website and let us know what's on your mind. Thanks for watching Real Possibilities.